Welcome to Best Areas Digital Space. Today we are going to discuss on the topic mandibular fracture management. As you all know, the basic principles of fracture management are reduction, fixation, and immobilization. So to familiarize with the parts of a mandible, you can see the condyle, condylar head, neck, coronoid process, angle and ramus, body, parasymphysis and symphysis region. Now, coming to the reduction, the fractures can be favorable or unfavorable depending on the displacement which are caused by the muscle attachments. So, in favorable fractures, we go with the close reduction, and in unfavorable fractures, we go with open reduction. Now, what are the approaches for mandibular fracture management? We can approach a mandible through the existing laceration, through intraoral vestibular approach. And in case of symphysis and anterior mandibular body fractures, we can go with the submental approach. And in ankle regions, we can go with submandibular and retromandibular approach. And in condylar regions, we go with the preauricular approach mostly. It all depends upon the size of the wound or the site of the fracture. Now, how do you fix a fracture? We can fix a fracture either by a rigid fixation or semi-rigid fixation. So rigid fixations include usage of compression plates, reconstruction plates, and lag screws. While in semi-rigid fixation, we go with transosseous wires or non-compression mini plates. These are the most commonly used fixation method, mini plates. They are made up of titanium mostly. Now, methods of immobilization can be classified as IMF, osteosynthesis without IMF, osteosynthesis with IMF. Now coming to the IMF that is intermaxillary fixation of the uh, fracture can be done using bonded brackets as we do in orthodontic treatment. In dental wiring can be given like direct wiring or eyelet wiring. Arch bars, direct arch bars, Zelenko arch bars can be given. Cap springs are also preferred in IMF. Now, this is without IMF, we can use compression plates, non-compression mini plates, small plates, and lag screws. And with IMF, we use transosseous wiring, circumferential wiring, external pin fixation, bond clamps, and transfixation with Krishna wires. Now, what about the period of immobilization? So how do you decide how much time we need to immobilize a fracture? Now, there is a criteria for that. That is, in an young adult with tooth removed from the fracture line, receiving an early treatment, we can go for a 3 weeks immobilization. While if the tooth is retained in the fracture line, we need to add 1 more week. And if the fracture is at the symphysis region, we need to add 1 more week. And if the age of the patient is greater than 40 years, we need to add 2 weeks. And in case of children or adolescent, we need to subtract 2 weeks. Now, for your information, just calculate a 40-year-old lady fractured symphysis with tooth retained in position. So since it is a case of a 40-year-old lady, we add 1 more year, and since it is a symphysis fracture, we add 1 more year. Therefore, it becomes 3 plus 1 plus 1, that becomes 4, and then the tooth is retained in position. So we add just another 1, that gives a total of 6 weeks of immobilization. Now, coming to the details. So how do you write on an exam question of how do you manage a mandibular fracture is based upon these criteria. Now, coming to the details of each compression, each osmosis method, you can see compression plates. Compression plates are fixed, are used in rigid fixation, or they give a rigid fixation. That is, there is no interfragmentary gap between the fractured fragments. They get completely adapted to each other. That is, the earlier anatomic reduction position is retained, and then there is no formation of intermediate callus. And in such cases, in usage of compression plates, we can see a lower border chance of splaying. There is a splaying of especially in case of symphysis fractures, if we're giving a compression plate, there is a chance of splaying of the lower border. That is, this lower border gets separated from each other. Now, this can be prevented by the addition of an IMF. That is, we give a tension band of arch bar or mini plate in the upper border also. That is how the compression plates work. Now, as you all know, there is certain principles for the fixation. That is, there are lines of osteosynthesis, that is, Champy's lines of osteosynthesis, based on which we apply the compression mini plates. Now, as you can see, the line extends from the superior border in the ankle region. It extends along the line of the inferior alveolar canal, and then anteriorly it shows two lines. So in the ankle, we can give a single plate on the upper border at the external oblique ridge. While posterior to mental foramen, we can give one plate between the inferior alveolar nerve and the tooth roots. And anterior to the mental foramen, you need to give two plates. That is, one is subapical of the other at the lower border. So in symphysis region or anterior to mental foramen, we need to give two plates for stabilization. While in the ankle region, we can give a single plate in the upper border according to the Chamby's lines. And posterior to mental foramen, that is in the body of the mandible, you can give one plate between the inferior alveolar nerve and the tooth roots. Now, based upon the site, if you're asked a question of how do you manage a mandibular fracture at the ankle. Now, what is the specialty of ankle? Ankle has a lot of muscle attachments. As you can see, there are as you know, we classify ankle fractures based upon the favorability. That is, there are favorable and unfavorable fractures. So, in case of unfavorable fractures, what happens is we need to go for an open reduction and rigid fixation because the fracture is displaced against the favorability by the muscles. So, we need to reduce the fracture openly and fix. Now we can use transverse wires, we can use lax to slow fixation, or as we have already told, one mini plate on the external oblique ridge can be given. And the approach is usually extraoral or intraoral approach can be given. Also, there is an extraoral transbuccal approach. We use certain instruments transbuccally because the plating of ankle is difficult in view of the site, or its position is difficult to plate from inside or intraorally. So we go for an extraoral approach with transbuccal instruments. Also, in angle fractures, mostly proximal posterior parts get displaced lingually and superiorly due to the action of medial pterygoid muscle. In angle fractures, the proximal posterior part usually get displaced with the lingual and superior direction. Now, when coming to symphysis fractures, since it is a midline between the genial tubercles, there will be minimal displacement. While lateral to the midline, the fragment with genial tubercles is displaced linkally by the geniohyoid and mylohyoid muscles. Now, in adults, we can give distance wiring, and according to Chamby's principles, we can give fixation of two mini plates, one subapical region and one in the lower border, parallel to each other with a gap of 4.5 millimeter. Why do you give it in the subapical region? Because not to injure the roots of the tooth. We give below the roots of the tooth, and the other plate we give at the lower border. Now these are to neutralize the. Why do we give two plates? To neutralize the torsional forces. No, mostly on rigid fixation, you can get questions on dynamic compression plates or eccentric dynamic compression plates, lag screws, locking plate, reconstruction plate, and top. Now, load bearing usually the plates can be classified as load bearing and load sharing. So reconstruction plates are considered to be load bearing, while load sharing are mini plates. Now, and also I forgot to tell you that rigid fixation happens, or healing of rigid fixation happens by primary healing, while fixation using a semi-rigid plates or semi-rigid method leads to a secondary healing. That is, there is formation of granulation tissue and delayed healing is found in semi-rigid fixation. While rigid fixation, there is complete approximation of the anatomical fractured fragments in the previous anatomic position. Therefore, it heals by primary intention or primary healing. Now, as you all know, this fracture healing can be primary or secondary. In primary healing, it is further divided into contact healing and gap healing, depending upon the amount of gap that exists between the fractured fragments. Now, in contact healing, there is no or less than 0.5 mm of gap is present between the fractured fragments, so it heals by contact healing. While in gap healing, there is an interfragmentary gap that exists. Now, coming to the complications, in majorly, we need to know about eburnation. It is a non-union of mandibular fractures, which causes an elephant foot-like appearance. There is sclerosis, especially it happens in long bones with sclerosis of the bone ends. And there is a non-union happening between the fractured fragments. Now, that winds up the gist of mandibular fracture management. In an exam point of view, we need to read about the other complications of mandibular fractures, and also you need to read about the rigid fixation methods. You need to read about dynamic compression plates and eccentric dynamic compression plates, because that can be asked as short notes. Okay, to revise, we need to answer the mandibular fracture management questions based upon the question. That is, if it is asked that how do you manage a mandibular fracture on the ankle, it is different. While how do you manage it on a symphysis? That is also different. So based upon the site and based upon the age of the patient, the fracture management of the mandible varies. Okay, we'll continue with the condylar fracture management in next class. Thank you.